Hi everyone, my name is Karen Murphy and I handle the outreach activities for the Montana Health Co-op. Thanks for agreeing to join us today for this introductory webinar. I know that schedules are very tight, so I will do my best to complete the presentation as expeditiously as possible. It should take about a half hour. Let's talk a bit about our agenda today. First of all, I want to do a kind of an overview on Montana Health Co-op, who we are, how we got our funding. Talk a bit about the Affordable Insurance Marketplace, which is also known as the Exchange. Then jump to an overview of the Affordable Care Act, a brief discussion about PPO and HPN network participation models that we offer, and then talk about our third-party administrator, Altius, which is based out of Salt Lake City. Montana Health Co-op is set up as the typical cooperative model that's familiar and accepted throughout Montana and in most rural states. We were created by Montanans for Montanans, and our initial funding came in the form of a $58 million loan that was distributed under the auspices of the Affordable Care Act. Now, this is a loan and not a grant, and eventually the funds need to be paid back. You know, and it's interesting to note that co-ops as a health insurance model were established as a bipartisan alternative to the single-payer model of care, which was also known about 3-4 years ago when the Affordable Care Act was being discussed. It was also known as the Medicare for All method of payment, or a government-run insurance option. Now, that didn't fly for a variety of reasons, but it's interesting to note that the co-op model was actually agreed upon as a bipartisan alternative. Co-ops are really, truly a different insurance paradigm, and they were set up as a means of fostering competition among entrenched and established insurance companies, and as a model that would, hopefully lower the cost of premiums for people because of, the member-operated, member-oriented model, and the fact that, they are established with the directive of offering affordable and comprehensive insurance to the currently uninsured. Let's talk a little bit about the exchanges under the Affordable Act. Now, the exchanges, for most folks, really are the touchstone of the Affordable Care Act, and it's where most Americans will interact most directly with the law. The exchanges themselves have been rebranded at the federal level, and they're being called Marketplace now. So don't get confused. Exchange and Marketplace, it's essentially the same thing. And what it basically is a web page. Most folks will access and purchase and investigate their insurance options through the exchange from the comfort of their own homes. Now, there will be a 1-800 dial-up option for those people who are uncomfortable using the insurance, and those folks will interact with staff that are termed navigators, who will help them determine their eligibility for premium subsidies and effectively guide them to a policy that would be most effective for their healthcare needs. The neat thing about the exchange is, for the first time, it collects a variety of healthcare policy information and allows individuals to compare those in a very, like an organized fashion, where similar plans are placed together and grouped together so that people can very efficiently and easy compare the differences in benefits, the differences in premium costs, perhaps the differences in the provider networks associated with each plan. And now, because these plans are on the exchange and folks will be making purchases on the exchange, the plans that are actually on these websites need to play by specific rules. And number one, those plans need to be affordable, which is the big carrot. And number two, they need to be comprehensive. And this is different from much of the health insurance that's available on the individual market now. The feds have determined and defined comprehensive insurance under the precept of essential health benefits. Now, essential health benefits, that's a comprehensive package of items and services that fall in about 10 different categories, and those categories of benefits include, ambulatory patient services, hospitalization, maternity and newborn care, ER services, mental health services, prescription drugs, labs and rehab, preventative and wellness services, and many of these benefits, are really unavailable in the individual market. Often folks would buy very extensive plans that didn't offer much coverage at all, and that's not the case with the plans that are offered on the exchange. Now, the big carrot for the plans and for the plans to be on the exchange and for people to shop on the exchange is the availability of those premium subsidies. So in order for an individual to qualify for a premium subsidy, the purchase has to be made on the exchange, and in order for a plan to be to qualify for those benefits, the plan must be offered on the exchange as well. So that's why I'm saying that the exchange itself really is the touchstone for most people of the Affordable Care Act. It's interesting that there are estimated 278,000 Montanans could get insurance via the exchange. That's a number that comes from the Bureau of Business and Economic Research from the University of Montana, and that's a combination of the uninsured population in Montana, which is really 20% of the statewide population, and those who are currently purchasing insurance as individuals. Again, that's spotty. That coverage is spotty. It's expensive, and we are anticipating that those individuals will actually maneuver to the exchange to buy better plans at a much more affordable price. And I have also just an interesting stat on there that Congress and their staff, by law, will get insurance from the exchange starting in 2014. So again, let's look at the exchange itself, and I mentioned that the exchange will be set up as basically a web page. So what you basically will do is launch a web browser on your computer, go to a specific URL or website. That website address has not been released, and we haven't really seen what the exchange will look at. But for Montanans, we will access the federally facilitated insurance marketplace /exchange. If you'll remember back when the Affordable Care Act was being discussed and the term of exchanges was thrown into the mix, states were given the option to develop and maintain and set the rules for their own exchanges. And if states decided that they refused, just didn't want to play by the game and didn't want to, take on the responsibility of setting up their own exchanges, the Fed said, that's fine. If you don't do it, then we're going to step in and do it. And that's basically where Montana is. Our folks in the state said, forget it. We don't want to set up our own. You guys go ahead and do it, and we'll jump on board. So that's what we're doing, and that's what a number of other states are doing as well. So Montanans will, in fact, hit the federally facilitated insurance exchange and will maneuver to the Montana portion of that exchange. Now, Montana is, as a state, is considered to be a benefit-rich state, which means that by law, policies sold in Montana to service Montanans have to cover a variety of benefits that perhaps aren't available in other states, and those laws are set by Montana. The rules and regs in place for those policies will also apply to policies sold on the Montana portion of the federally facilitated exchange. So again, we go to a marketplace. It's the federal exchange, and we just simply maneuver ourselves to the Montana portion of that exchange. Let's talk about the way that this exchange will actually be set up. So again, the precept of this one-stop shop, this internet shopping place, is that we'll be able to compare apples to apples. And in an attempt to do that, the plans themselves will be structured in different tiers of coverage. And you'll hear these plans that are organized according to these tiers, you'll hear them referred to as the metallic plan. So we're going to have a gold and a silver and a bronze tier, and there will also be another tier that's actually above the gold standard, and that will be called the platinum tier. Just for purposes of explanations, we just kind of kept it busy here, or kept it simple here with these three different tiers. Now, each of the tiers that qualify, or each of the programs that qualify under the gold level of coverage, and that gold level determines certain out-of-pocket costs, costs, premium costs, and different benefit structure, they'll be grouped together in one tier. Those categories as kind of a mid-range plan will be grouped together under the silver tier, and those grouped, as the least expensive option will be grouped under the bronze tier. So all plans will be grouped into those specific tiers of coverage. So on here, if you look on the slide, I've got an example of just 2 plans for each tier of coverage. Now, there may be 1, there may be 2, there may be 5, there may be a dozen, there may be 20. We really don't know. But those plans from a variety of different insurance companies will be grouped together so that individuals can very easily compare and contrast what each individual plan offers. And this is different because often we had to call, a variety of insurance agents, visit a variety of web pages, and really spend a lot of time poking around and determining and comparing the different plans before we could actually determine which one we wanted to purchase. This is a one-stop shop now, so things will be located in one specific location to ease that burden and make this a lot easier for us. I want you to focus on that silver tier of coverage, and specifically the second least expensive plan that will be offered on the silver tier of coverage. That plan will basically be the basis. That will be the core plan that will be used to determine the federal premium subsidies that are available for other people. So that second least expensive plan on that silver tier of coverage, that's what the feds will look at and say, that's what we're going to base your federal premium subsidy on, the cost of that plan, if in fact you do apply, you qualify for that, for those subsidies. And that's interesting because that tells me that the feds are really taking a middle-of-the-line approach. They're not taking the cheapest bronze plan, which would be the least expensive one offered on the marketplace, and they're not taking the most expensive gold plan, which would be the most expensive plan. They're basically taking a middle-of-the-road approach, and we'll explain this a bit more. Let's look at the plans in specifics and how they really will be organized. So, for example, and again, these are those metallic plans. We're missing the platinum tier, which is a step above the gold. But for purposes of discussion, gold plans, for example, $600 deductible in 80/20 pay structure, $1,500 out of pocket. So all plans that would fall under that gold tier of coverage would play by those rules. There may be some differences between the plans, but you would be able to very easily compare what those differences are. Now, what we've been told is that those out-of-pocket costs for each of the tiers are changing, and those are determined and defined at the federal level. I can tell you they won't go down because prices never go down. They will, in fact, go up. We just don't know what those actually are right now. But this is basically what we're looking at for those plans. Note the deductibles. They're not big. We're not talking about a $7,000, $8,000, $10,000 deductible, which is pretty much the norm in the individual marketplace now. So this is, in fact, quite a bit different than what we've been accustomed to. So let's take a look at how these subsidies will actually work. This is an example for an individual who makes $34,000 a year. Now, the subsidies themselves will go up and cover, well, not cover, but they will augment, help individuals pay for premiums if those individuals earn between 100 and 400% of the federal poverty level. Now, for this individual, we've got a $34,500 income, and that hits, for a single person, that hits at the 300% of poverty level. So that salary is 3 times the base level for the federal poverty level. So now we look at the $7,500. We are just supposing that that is the base plan. So that would be the second least expensive plan offered on that silver tier of coverage. So for this individual's age, the annual premium for that plan would be $7,500. Now, the feds have defined affordability based on percent of income in relation to where salary falls on that poverty level. At 300% of poverty level, the feds have determined that 9.5% of income is the definition of affordability. So this person would not pay more than 9.5% of income for that $7,500 subsidy, which means really the out-of-pocket for that individual is $3,279, and the government pays up, makes up the rest in the form of the tax credit subsidy, which would be $4,200. So again, the big thing here is that we're looking at that poverty level, and we are determining affordability based on a sliding scale, and that's a sliding scale percentage of income, depending on where that salary falls on the federal poverty line. Another example, this is for someone who earns substantially less. This is an individual earning $16,100 a year, and you know this is only 140% of poverty level. The prior example was 300%. Again, we're looking at that same base premium, that second least expensive plan on that silver tier of coverage. We'll assume that this individual is the same age. So again, that cost is the same. That annual cost is $7,500. Note the definition of affordability for this individual is only 3.41% of income. The other person at 300% of the poverty level was a 9.5% income. So again, the definition of affordability is ratcheted down. That means this person is going to pay $550 out of pocket with a government subsidy of close to $7,000. So we're looking at big money here, folks, big money for individuals to really alleviate the pain of those premium subsidies, and we're also looking at big money coming from the government. So again, these are plans that need to be purchased off of the exchange/marketplace place to qualify for these premiums. This is just a sample. I wanted to throw this up to show you the different ranges of incomes for the federal poverty level. These are based on 2012 numbers, and I've been asked, well, where can I get a copy of this? Any kind of a Google search for federal poverty level will throw this chart up for you, because this is really used as the basis for many federal programs, eligibility for those programs. If you look, we go from a family size of 1 on this graph up to 6, and note that the core for an individual, the core poverty level income is $11,100. Again, these are 2012 numbers, and close to, an individual earning pretty close to $45,000 a year would actually qualify for federal premium support. So that's for Montana. $45,000. We've got a lot of folks who fall below that. And note, for a family of 4, they can earn up to $92,000 in 2012 numbers and still qualify for federal premium support. Those exchanges, that marketplace, the rules are that they be up and running by October 2013. Open enrollment goes from October to January, and the plans actually become effective in January of 2014. Let's talk a little bit about that and go into some difference, some specifics. Again, this was 3 years ago that it was signed into law. One of the precepts of the plan was that there would, in fact, be Medicaid expansion, so that individuals earning up to 138% of federal poverty level would be covered by Medicaid. There's a lot of discussion regarding that, including here in Montana. We'll see if that will actually be accepted by the Montana legislature. We need to pay attention to see if they will agree to that expansion and the use of federal money to actually allow that. There are tax subsidies available now to help small employers offer health insurance to their folks. We talked about the premium subsidies and the exchanges. Consumer protections, there's a big range of changes now in the insurance industry, and one of those is related to pre-existing conditions. There are no more clauses for pre-existing conditions. Pre-existing conditions starting in 2014 thrown out the window. That means that there are no premiums are not adjusted to reflect a history of health conditions. Likewise, gender adjustments are no longer allowed. Age adjustments are allowed, but they're limited. There are only really three factors that can be used to adjust the premiums. Number one is age, but that's limited to a 3-to-1 margin. So the oldest individual will never pay more than 3 times what the youngest would pay. You can also adjust for smoking, so smokers can only pay 1.5 times more than non-smokers, and we can also adjust for geography. Note also there are protections now against unreasonable rate increases, and that's also known as the 80-20 law, where 80% of the monies now that health insurance corporations collect need to be actually spent on benefits and claims payment. And if that's not the case, the money needs to actually be returned to the members. Again, covering everybody with insurance, the big push is to get everybody in to see a primary care doc. An ounce of prevention is obviously worth a pound of cure. And again, the uninsured, their health care up to this point has been basically the emergency room, which is, as everybody knows, the most expensive point of entry into the healthcare system. So by encouraging coverage and preventative care, we hopefully keep a handle on healthcare costs. And the other thing is what was known as the insurance, the individual mandate, that everyone does in fact have to have insurance, and that is a deal. It's not something that the police can come and arrest you for if you don't have coverage, but if you don't have coverage, there are tax penalties that are slapped onto you, and we'll talk a little bit about those as we. No more lifetime caps on how much companies can pay. So, for example, $1 million cap on a policy, which is basically exceeded during one catastrophic illness, that's out the window. No more retroactively covering coverage based on a perceived paperwork error. We talked about pre-existing conditions being out the window, and we also talked about no more differences as far as rates for preventative services now. Fully covered by insurance. There's a full list of what the preventative services are at healthcare.gov. I'll talk a little bit about that website also as we move forward. I mentioned the 80-20 rule as a way of controlling costs, so that 80% of monies actually do go directly toward coverage for individuals. This I wanted to throw up, $400 billion in charity care bad debt in Montana last year. That's a big chunk of cash. As I run around and give this presentation to different people, I get a lot of comments about, well, how are we going to pay for all of this? The fact is we're really paying for it right now. If you look at that $400 million number, that's a lot of money, and that doesn't just disappear. That's actually distributed, and we're all paying for it. And these are all things that we've discussed up to this point. We've talked about the subsidies. I hope that those are clear. Again, they're available for individuals earning between 100% and 400% of the federal poverty level, which is a fairly wide range of income, especially for folks in. How is this all going to work? How do we prove that we actually do have coverage? Well, in 2015, we will receive notice of insurance pretty close to a W-2 that we will file with our taxes. I've had people say, well, what if we have a break in coverage? It looks like the law is allowing a 90-day break in coverage throughout the year, which would still mean that you have, in fact, had coverage or have had qualifying insurance throughout the year. If your income is too low to federal a tax return, there are no penalties for you because the penalties are tax-based. And really, if you don't play by the rules and you don't get coverage in 2014, really we're talking about a slap on the wrist. It's a $95 tax penalty for an adult, $47.50 per child, up to close to 300% for a family, which is significantly less than the cost of insurance. So that is correct. It is simply a slap on the wrist for the first year. However, as the years progress, the penalties become more and more onersome. For example, a couple years down the road, the penalty is actually $100 more than the actual cost of having maintained insurance throughout the year. So, at that point, it becomes kind of a no-brainer where you really do want to have the insurance, or you're just throwing money away in the form of a tax penalty. Let's talk about Montana Health Co-op PPO and HPN networks. We are developing right now a standard PPO statewide network, and we're inviting providers to join us in that. We're also collaborating with different healthcare systems to develop a high-performance network, and those healthcare systems are actually reaching out and inviting providers to join with them. This is a gain share focus. For the HPN, Montana Health Co-op is not involved in any clinical-based decisions, and we believe that the HPNs will actually be regionally based with a focus on value-based outcome, including evidence-based care. If your organization is currently participating in the Coventry Network, no credentialing paperwork is needed. We've sent out mailers, and we ask those who would like to participate with us to sign the network participation agreement, get it back to us. Please include the W-9. If you've got any questions, give us a call at the number on your screen, or email us, provider@mhc.coop. And one thing I want to throw out here is that as an organization, our difference is that we are truly focused on getting the uninsured coverage, getting them covered under our policies. And we're working hard to keep those policies affordable so that they will actually jump on the bandwagon and make your life easier as well. We are specifically set up to offer that coverage. We have made a commitment to do that. We are definitely going to be on the exchange for the first year. That's part of our mandate. And, you know, there are a number of companies who won't participate in the first year because, you know, the cost of insuring the uninsured at this point is kind of a big unknown. But we're there. We're offering our premium and working hard to give those folks the coverage that the other thing we want to talk about briefly is we have, in our attempt to keep our costs as low as possible, we've selected Altius as our third-party administrator. This is a solid and established organization that works hand-in-hand with Coventry. They offer prompt and accurate claims payment, electronic funds transfer. They've got live customer service reps available for a good portion of the day. And we will have easy access to their web portal for both members and providers to pull in data and services and reports. Moving things to keep your eyes open. The big thing is, will the Montana legislature open its arms and accept the Medicaid expansion? Governor Bullock has presented his plan. It's called Access Health Montana. Stay tuned to see what happens with that. What other insurance agents or companies will participate on the Montana portion of the federally facilitated exchange? Not sure yet, so stay tuned and we'll see who else jumps into the fray. We're seeing a paradigm shift from group coverage to individual coverage, especially in light of the money available for those insurance premiums. Small companies look at those premiums and think, you know, that's solid coverage on the exchange. Maybe it would be better for all of us to just get out of the insurance industry and send our people directly to the exchange. So we're seeing a bit of that. If the more people have coverage, the more use of primary care physicians we're going to have. And do we have enough primary care providers to cover those folks? We will obviously see dramatic changes in the healthcare market as the years march forward. What specifically those will be, nobody knows, so that will be interesting. And I thought this was fascinating. Again, this is stat that comes from the Bureau of Business and Economic Research from the University of Montana. They expect 354,000 Montanans, now our population is just a hair over 1 million, that number of people, they expect to see a change in insurance, a shift of some type, moving from a group plan to an individual plan, moving from uninsured to Medicaid, maybe moving from an individual plan to Medicaid coverage. But that's a huge number to expect some type of change in insurance by 2014. And the other thing is, know that there's still a lot of fine-tuning and clarification and definition of rules being determined by the Affordable Care Act, so we all need to simply pay attention and see what the scoop is. And the last thing I want to throw up there is www.healthcare.gov. That's a fabulous website, very clearly maintained with lots of printable material, and that website was actually set up under the umbrella of the Affordable Care Act so that people had one place to go to keep up with all of the changes in the industry. So when people ask me, well, where can I go, to keep abreast of all the changes, that's the site, and I've been directing many people to that. In addition, our website will be up and running shortly, Montana Health Co-op, and we will have a calculator for individuals to determine what the size of the federal premiums that they would be eligible for. So again, we're telling people to visit our website. That's the presentation. I hope this clarified the Affordable Care Act. Hopefully it clarified who we are at Montana Health Co-op, answered some questions about our different products that we'll be offering. Thank you so much for your time. It'll be an interesting ride as we move forward. Thanks again. Have a great day.